How's the sound? You can hear? You guys can hear okay? My name is Mary Lou Jackson, and I'm Director of Vision Rehab at Mass Eye and Ear in the Harvard Department of Ophthalmology in Boston. And what I want to discuss briefly with you over the next 20 minutes or so is not the how to do a NIDEC perimeter or any other kind of macular perimetry, but rather the why. And I'm going to explain this from the perspective of vision rehab, but definitely some things here apply to any ophthalmologist wanting to do macular perimetry to manage other diseases affecting central vision. I don't have any financial interest in NIDEC or NIDEC products. So there are two main reasons why we're so interested in macular perimetry and in central visual function. And they relate to, first of all, fixation, and secondly, scotoma and information about that scotoma. I'll talk about two cases that I think are particularly interesting, not just in vision rehab, but in general ophthalmology. One is ring scotomas, or foveal-sparing scotomas, that are actually very common in macular degeneration, both geographic and exudative, and secondly, hemianopsias. So the first question is, where does perimetry fit into comprehensive vision rehab? This is a circle, and the patient goes all the way around, and you can see at the 9 o'clock position, that's where perimetry fits in. It's in when the point of the care that we do an evaluation of visual function. But if you're an ophthalmologist, you in fact are at that 6 o'clock position. That's where you make diagnosis and detect patients who have loss of vision function. Those patients are referred for a vision rehabilitation assessment or consultation, and then they move along to 12 o'clock. Occupational therapist is Medicare funded, and they do tremendous work with our patients to assist them with various things, which I'll show you. And then in all of our communities, at the 3 o'clock position, you'll see a number of other sources of support for patients with vision loss. So perimetry fits into this continuum of care at the 9 o'clock position, where we're doing evaluation of remaining vision function. This is what is addressed in comprehensive vision rehab. This is the way it's published in the Academy Preferred Practice Pattern, Vision Rehabilitation for Adults. I'm really going to be addressing reading, but just briefly the other 4 activities or things that are there. Activities of daily living. There's a lot that can be done to address patient goals. There are standard old-fashioned magnifiers, if you will, but in addition, video cameras and screens are put together now in many hundreds of models, and they're video camera magnifiers. They change people's lives. Computers, there's accessibility, there's audio, there's magnification, and so on. So in comprehensive vision rehab, we address that patient's activities of daily living with devices and strategy. We address safety, fall prevention. Can a patient who loses vision still see to take their medications? Are they cutting themselves in the kitchen with a knife? It's part of vision rehab to address that. Participation. Loss of a driver's license is a really big issue for patients who lose vision. It needs to be addressed. It impacts independence. Transportation alternatives, driving cessation, again, part of vision rehab. And then certainly patient well-being. A third of the patients seen in vision rehab have clinical depression or are at risk of that. Another third have visual hallucinations, Charles-Bonnet syndrome. So these are issues that get addressed in vision rehab, comprehensive vision rehab. But the issue that we're concerned about now in terms of macular perimetry is reading and reading rehabilitation. When you walk around this hall or do various things in day-to-day, you're using peripheral or mid-peripheral field. But if we want to read, we're now using central 5 degrees of field. A patient with magnification might be using a bit more. But what's going on in that central 5, maybe 10 degrees becomes critical if one needs to understand and address reading and reading rehabilitation. We need to do macular perimetry to know, does that patient have a scotoma affecting that central area? If they do, how is that scotoma located relative to their fixation? And what's the configuration and the size of that scotoma? So you need information about any central scotomas present in the central reading area. That's one category of information that you get from perimetry. The second is about fixation. And if you or I were to look at a target, and we have good vision, you put your fovea on the target. It's foveal fixation. But when a patient has macular disease or a disease causing any kind of central field loss, they no longer are able to use fovea, and they may use an alternate area, what we call a PRL, or preferred retinal loci. They may use a couple of PRLs. Looking at a face, you may use one area of retina, and when you go to read, you may use a second. And they may or may not be aware of whether they're using a PRL. So you or I are looking at a target, and we fixate with a fovea. On the nidec perimeter, small blue dots are placed to indicate fixation. And whether you can see that, I'm not sure, but here you have those fixation dots all superimposed. So two bits of information there. Where is fixation? It's foveal. And how is fixation? What's the quality of that fixation? And in this case, all the blue dots are very closely put together. But look here, this patient has Stargardt's disease. That's the fovea. That's where that person would be fixing, but now post-rehab, they're using a preferred retinal loci, anatomically superior to fovea, and those blue dots are fairly close together. In rehab, that's a successful outcome. Down here, in contrast, you have many blue dots. These are all different spots of fixation during the examination, and they're now spread out over a wide area. So when we're doing macular perimetry, we want information about fixation. Where is it, and how good is it? Very important to us in rehab. I want to mention this just briefly. We don't see with our eyes, we see with our brains. And the research that's coming out of neuroimaging is still somewhat contradictory and confusing, perhaps. There's still controversy. But there is certainly suggestion, and there's room to do more research, for us to understand whether there is reorganization or neuroplastic change in patients who use alternate areas for foveal, instead of foveal fixation, or connections that come to light as people use PRLs. So again, this becomes interesting as we're thinking about people who are using alternate, not foveal fixation. In this particular study, this is a patient with macular degeneration who's having stimulation at the fovea and not showing any activity, whereas a normal control looks at something with their fovea and has activity. In contrast, in this paper, the patient using a PRL now shows activity in what was an area supposedly that may have had foveal fixation when they had healthy vision. So again, there's some controversy. Not everyone is showing this, but it certainly is raising some interesting questions. Again, this is another paper that reviews some of the evidence about changes, cortical changes with PRL fixation. This, in fact, was a study that was the parameters around the fixation and the scotoma information was done on a nidec. And some suggestion here that visual stimulation with the PRL in the macular degeneration patients did show increased activity in the cortex in the areas that had taken foveal information previously. There are many ways that we could look at field information relative to central vision. And with the exception of the last two, so scanning laser ophthalmoscope perimetry or nidec perimetry, all of the ones above that on that list assume that a patient can fix with a fovea. When they can't, as it's in the case with so many patients, macular degeneration is certainly the most common example, the information you're getting from that perimeter is no longer, perhaps, accurate or valid. Amsler grid's been out there for a long time as a way to assess central field, but we now know, first of all, patients know, their brains know, that line should keep going, so we fill it in. And in addition, lots of patients can't, not by any ill will on their part, but they're not able to fixate centrally on that target. They're perhaps fixing somewhere else. So this is missing lots of information about scotomas, and even the information that you do get is very gross and perhaps even misleading. If you do a Humphrey field, that's predicated on an assumption that the patient can fix with a fovea, and not just fix with a fovea, but have good fixation. And what I've explained to you is that patients with central disease may not be fixing with fovea and may not have good fixation. It's over a broad area. So what do we need? When patients have macular disease, what